The All In Podcast is brought to you by the Urban League of Metropolitan St. Louis in partnership with the National Urban League, the National Action Network, Shea Moisture, and the National Coalition on Black Civic Participation.
We were learning new information every day. There's no exaggeration that sometimes when I'd be talking to individuals or giving lectures or giving talks or doing interviews, I would say something different the next day because we got new information. I mean, it was coming so fast. I want to go back and also just say thank you to you and the Urban League for being that very trusted source that has helped make a difference. You know, we're in a battle now against, mis and disinformation, and we, and you're play such a critical, important role. And I thank you for all the lives that you have helped to save.
Good day. Thank you for joining us on this edition of the All In Podcast. I'm your host, Pat Washington. We are all in against COVID, and we want you to be too. There are so many questions, so many things going on in our minds, in our communities about the COVID-19 pandemic. And we're lucky today because we have someone who's going to help us get it all sorted out. Dr. Stephen Lawrence with Washington University. He is an infectious disease specialist, and he's at Barnes Jewish Hospital. And so he's going to help us walk through some of the latest news and keep us up to date about COVID vaccinations, boosters, where we are in terms of community infection rates, just really what's going on with COVID-19 and what we really need to be doing. It looks like COVID is loosening its grip, but who knows? It could be here to stay. So President Biden's administration has recently announced that they are going to declare the pandemic over, or at least the emergency part of the pandemic is going to be declared at an official end sometime in May. What does that mean? What should we be doing? How should you be moving to continue to protect yourself? So we're going to look at all of those things. Dr. Lawrence, thank you so very much for joining us today.
Well, it's a pleasure to be here. Thanks for the invitation.
And can you tell us a little bit more about your background? And I know it says infectious disease specialist, but really, what does that mean?
Yeah, so I have gone through my medical training, first off, medical school and internal medicine residency, and then spent 3 years learning how to diagnose and treat people with all sorts of different infections. And when I finished up that training back now, it's been a little over 20 years ago. Since then, I've been focusing mostly on trying to learn about and help prepare the public for things like pandemics of influenza and now COVID, which was something we didn't expect a few years ago. And so that's where most of my expertise in infections lies, in those types of respiratory virus infections.
First of all, let me say thank you for that. Thank you for the work that you've done. Thank you for all the work that your colleagues have done in protecting us and keeping us safe. You know, you really are heroes when it comes to the public's health. And so I don't think there's enough gratitude in the world that we can express for that. So thank you.
Well, thank you. And certainly I share your gratitude for everybody who's in the hospital every day working, through especially or in the early days of the pandemic when it was really scary.
And we didn't know what was happening. There were people who were probably sick with COVID, but nobody even knew what COVID was at the time. And so that was really scary. You're absolutely right. But it looks like things are getting a bit better. And as we said earlier, President Biden's administration, they are going to sometime in May talk about the lessening or the easing up or totally doing away with most of the emergency declarations around COVID-19. So can you tell us, where are we right now with the pandemic?
Well, we are still in the pandemic in the respects that the virus that emerged 3 years ago is still with us. It is very likely going to stay with us for the rest of all of our lives and become a virus that we'll periodically see through the rest of our lives. And We think that it's likely to settle into a pattern similar to flu and colds, where most of the exposures, most of the illnesses will occur in the colder months. But in the first few years of a pandemic, like we've seen here, we've really seen spikes and surges that can occur at all sorts of times throughout the year. And so we're still not quite ready to say that this is just going to pop up in the winters, but it's pretty likely that, several years down the road, that's the pattern that it will settle into. Where we're at right now is certainly a better place than where we started. I think we can all agree on that, and that we've got a few tools that have made our ability to handle this virus so much better. And most importantly, it's the availability of really, really effective vaccines. And since those came out 2 years ago, we've still seen a couple of big surges that we've had to get through. But we're currently seeing at the moment is a gradual decline, both in our region and across the country, in the total numbers of infections, such to the point that it's something that's still present. People are still at risk of getting it, but we're not seeing massive numbers like 1 year ago when Omicron first came on the scene. We were seeing at that point crazy numbers where possibly 1 in 10 people were infected all at the same time back about a year ago. It's much better than that. We're at much lower numbers, but it's still circulating.
So talk to me a little bit then about people who are most at risk right now.
Yeah, the people who are most at risk of getting seriously ill are those who are older. And by this virus, this virus actually starts to affect people even over 50 a little more than others. But in particular, 65 is a cutoff that we use for higher risk for a lot of different infections. COVID is included in that. Those people who have a weakened immune system because of medicines that they're taking for other illnesses or because of other diseases. And certainly another one that's a very important one is pregnancy. People who are pregnant actually are at much higher risk of getting very seriously ill from COVID. And so those are groups that, and there are others, but those are the three major groups that would be at highest risk of more serious illness, and those that we really want to target to make sure that there's opportunity to be fully vaccinated.
Now, why are people who are pregnant, why are they more at risk than other populations?
That's a really great question. And we started to see, even with influenza, that that's the case. And this is something that we really learned in the 2009 H1N1 flu epidemic or pandemic. And that individuals who are pregnant may be 5 times more likely to get seriously ill than somebody who's the same age who's not pregnant. And so we think that some of it has to do with during pregnancy, the human body is in some ways a little bit immune compromised, because that allows the normal development of the fetus to, the immune system changes just a little bit. And it seems like part of those changes may be why people during pregnancy are more susceptible to more serious infections.
I understand. That makes sense. So if these are the groups who are, and they're likely the groups that we just talked about, those who are pregnant, those who are over certain ages, those who have, some underlying other health issue, they are likely to be at risk whether we say pandemic over or not. If it does even come out to be more of a seasonal type risk, they are still going to be at higher risk. Is that right?
You're absolutely right. And that's exactly what we've seen with flu. And so 100 years ago, a little over 100 years ago, there was the worst flu pandemic that we've known in history. And it was terrible. It was even more people died, and a higher percentage of people infected died than what we saw with COVID. And since then, though, influenza then kind of settled into a seasonal pattern where every winter we'd see people getting sick. But before COVID, every year between 15 to 80,000 people in the United States died from flu every single winter. So flu, even though it was not even in a time when there's not a pandemic, is another very serious respiratory virus that we've needed to pay attention to and try to come up with vaccines and other ways to prevent it, because in a regular year, tens of thousands of people die from it. And absolutely, we would expect to see that with COVID as well, that once we really truly get into more of a, what we say, steady state or kind of a consistent seasonal pattern, there are going to be probably tens of thousands of people at risk of dying every year, even in a quote unquote normal year.
Wow. And you mentioned earlier, we talked about the Omicron. Can you walk us through the different variants? You know, we started with one. Now I think there seem like there are 50. I don't know. But can you give us the status and just tell us how we progressed from the original discovery or understanding of COVID to where we are now?
Yeah, sure. So when it first came, it was discovered in the very first almost year or so, the same original virus that emerged it was spreading throughout the world. And that one was a little more severe, caused more serious illness and more likelihood of causing death. And then it started to mutate. And when it started to mutate, it would, there are what we call variants that suddenly after mutation, they become either more contagious or have greater ability to escape the immunity that we get from either previously being infected or from vaccines. So, about a year after the original virus came out, there was a variant called Alpha, and that one just was more contagious. It wasn't more serious. And then there was one called Beta that didn't hit the US very much. But the one that really hit us hard was Delta. So, the Delta variant hit in around September of 2021 and the late summer, early fall. And that really caused a lot of damage because that virus was still very nasty, and it was severe, and it also was able to evade some of the immunity that we had built up from people who've been getting vaccines for the 9 months. And so we saw a lot of people sick with Delta and a lot of people in the hospital, and it caused a big surge and even a lot of deaths associated with it. Soon after Delta started to fade away, that's when this Omicron hit. And that is the variant that we are still seeing today. It came about in, say, December of 2021 or about a year ago, January of 2022. And we saw the highest numbers we've ever seen for any kind of infection through really all of modern history. And during the peak of Omicron back in January a year ago, we were seeing infection rates that some estimates were between like 1 in 10 to 1 in 5 people were all infected, pretty much around the same time.
Oh
The
my.
numbers were huge. The good thing about, if there is a good thing, there's a silver lining with Omicron, is that it was the mutations that gave it the ability to make it super, super contagious, like almost to the point of like chickenpox. And, for those of us who are old enough to know chickenpox, it was crazy contagious.
Yes.
And so Omicron was pretty similar in how contagious it became, but it also became a little milder. And so even though more people were getting it, it wasn't causing as many hospitalizations or deaths relative to what Delta did. And that's
So it was easier to spread.
right.
It was easier to contract, but you may not be as ill from it.
That's right. Yes.
Okay.
And we tend to see this as a pandemic comes along and viruses change over time. Those mutations occur. In prior influenza pandemics, we've seen a similar pattern. The virus tends to get a little milder over time as it sort of becomes, humans and the virus sort of learn to live with each other in some ways.
Mm-hmm.
And this same Omicron variant now has been around for a year, but it has all these subvariants, and there's been dozens of them that have popped up. And, they're not super important to remember. There's BA1, BA2, BA5, and now we're in XBB15 is the major one.
Oh my gosh.
But you know what? Those numbers don't matter that much. It's still all generated from Omicron and from a year ago. And because of that, what that means is that it's a super contagious virus, but so many people have been infected, and so many people, not quite enough, but a lot of people have been vaccinated too, so that most of the country has either been vaccinated or infected by this point. And when that happens, then after vaccination or after infection, our body's immune system provides some pretty significant protection versus getting seriously ill. Now, it doesn't give us long-term protection from getting mildly sick, but it does give us really quite good protection versus becoming hospitalized.
So even with those protections, though, does that give you protection from all of the different variants? If there's another one that should come up, if you, let's say I had Omicron, does that mean that I still have some protection against Delta or XBB or whatever happens to be the name that we all are hearing about lately?
Right, and there'll be some. And so, what happens when as the virus changes, we'll have still some immunity versus some of the older variants too, if they were to come back. The What we expect to happen is at some point in the future there may be a new variant that is even more contagious or easier to evade our immunity than Omicron was. We don't know when that's going to happen. We don't know how aggressive that virus would be, but we're always on the lookout for it. And the protection that we get from the vaccines and from even Omicron infections will give us some partial protection.
Mm-hmm.
The thing is, that it's a little bit of it's a tough concept to think about compared to, say, something like measles. So all of us who get measles vaccine, that vaccine is so good that basically you're never going to get it. You're never going to get infected. You're good for life. You're going to be 100% protected. You got the vaccine. You're never going to get it.
Is that a one and done situation?
One and done. That's
Okay,
it. It's one and done. But you know what? With COVID vaccines, and it's the same way with flu vaccines too, and it's more because the virus is trickier, is that we don't get lifelong protection. But what we do get is every time that we get another booster or another dose of vaccine, or we get infected with the virus, that every time that you have one of those either exposures or vaccines, you just build up more and more immunity such that it will give you really good protection versus getting very sick. But the protection versus like real mild illness starts to fade away within a few months. And so it's a bit of a frustrating situation. In fact, I've heard many people say, and I have, this is where a lot of the conversation comes from, is that, well, I got the vaccine and then I got sick anyway. But you know what? That vaccine may have saved your life, or it may have saved you from being in the hospital, because what we've learned is that the vaccines are very good at that. But what they're not able to do, because the virus is so tricky, is keep us from getting mild illness, after about 3 or 4 months.
That's a great segue into the vaccinations. And when we come back from this break, I want to talk to you more about the vaccinations, about the boosters. Should we still be getting vaccinations? Should we still be getting boosted? And if so, which ones? Which ones are still effective? Are there any new ones on the horizon? So we'll talk all about vaccines when we come back from this break. We're talking with Dr. Stephen Lawrence. He's at Washington University and Barnes-Jewish Hospital in infectious diseases. And we are talking, just bringing ourselves up to speed about COVID and COVID vaccinations and what's happening in our community. Stay with us. We'll be right back.
You're listening to the All In Podcast. It's brought to you in part by the Urban League of Metropolitan St. Louis. We're all in against COVID-19, and we want you to be too. Visit our website at ulstl.com for important information for keeping you and your family safe. Remember, we're all in against COVID.
Welcome back to the All In Podcast. I'm Pat Washington. Thank you for joining us. Today we're talking with Dr. Stephen Lawrence. He's at Washington University and he's an infectious disease specialist. And we are talking about COVID-19. We are talking about the status in our community. And now I want to turn our attention a little bit to the vaccinations. I just got some information today. Dr. Lawrence, thank you again for joining us. And we looked at the COVID-19 rates and the initial vaccination rates and the booster rates in the state of Missouri. And I thought that was timely given that we just saw that the Biden administration is going to um, limit or raise or even do away with some of the emergency declarations around the pandemic. And in doing that, the first thing I thought about was vaccination rates and booster rates and what does that mean? So in Missouri, some of the latest data that was as of February 3rd says that we have 69.3% of the population in the state of Missouri who have been given their first dose, and 59% statewide have had a second dose. Can you tell us a little bit about, just where are we with vaccinations, vaccination rates? Are we still at a point where people still need to be doing testing and vaccination and getting those boosters?
Yeah, the vaccines have been the most important tool at getting us to the point where we're at right now. Because, before we had the vaccines, it was still a very dangerous situation for many people that getting COVID, in some groups, there's a 1 or 2% chance of dying from it. And while 1 or 2% in some ways doesn't sound that bad, you could think about if every 50 times you got into a car, you died, we probably wouldn't be driving very much. And so it was a very serious situation that the vaccines have helped to get us to where we are now, where the overall impact is much lower, much less. But that being said, there are still some, as we've talked about before, there are still those who are at really high risk who will still be at risk of getting seriously ill. Because of that, it's the most important thing to keep in mind right now is to be up to date with the COVID-19 vaccines. And there's, what does that mean? Well, I'll tell you, it is a little confusing because the
Yes.
numbers of vaccines, I lose track sometimes of how many vaccines I've had. In fact, 1, 2, 3, I've had 5 doses now myself, and that's what would be considered fully up to date for those who started, getting vaccines shortly after they became available. I'll explain that there's a couple of different types of vaccines. The most common one that just about everybody is getting now is the group of vaccines called the mRNA vaccines. These are the ones that are most used and they're very effective. We know a lot about them. We know how well they work. We know that they're safe. They're made by Pfizer and Moderna, and those are the ones that also there's a new version of it that became available a few months ago. That's called the bivalent booster. And so to be up to date right now, we recommend that everybody has had at least the first series of the original vaccine, which is 2 doses at least. And if you've had other boosters of it, that's great too. But then also, if it's been more than 2 months since you had one of the original vaccines, that you would then get the new, what we call bivalent booster. Now, what does bivalent mean? Well, what it means is that it's actually protecting against 2 different strains of the virus or 2 different variants. It has the original one that we've been protecting against now for 2 years, but it also provides protection versus one of the Omicron variants. And so it gives us wider protection, and it's a little bit more specific and gives us some additional stronger protection versus the Omicron that is circulating now. So the easy way to distill this down is make sure that you are up to date, which really means having had a bivalent booster. And there is going to be some changes coming, very likely over the next 6 months.
I had a feeling you were going to say that.
That's right. So, well, it has, one of the problems that has made it a little hard to keep up to date is that the recommendations are changing over the last 2 years since the vaccines first came out. The recommendations have changed frequently. And the reason for that is because we were learning new information every day. There's no exaggeration that sometimes when I'd be talking to individuals or giving lectures or giving talks or doing interviews, I would say something different the next day because we got new information. I mean, it was
Okay,
coming so
right.
fast. And so we're at a point now, though, where we believe that in with the exception of a new variant that pops up, when then everything changes. But if we continue where Omicron is circulating, say for the next year, we really believe that we're moving towards a point that will probably be what we're looking at in the fall, where we're going to recommend annual boosters, just like we do with flu vaccines. And to make it a little more convenient, it's very possible that within a couple years, we'll have combined COVID and flu shots that are just a single, combined in the same shot.
That was going to be my next question. Do you think we'll get to the point where we'll have combined COVID flu shots? And do you think there'll be one that will just cover any possible variant that could come up? Or
Uh,
is that just wishful thinking on my part?
Well, it's wishful thinking on all of our parts, but I'll tell you what, the first part, yes, I think it's pretty likely that we'll have some combined flu and COVID vaccines just to make it convenient, because we're moving towards a likely scenario where we'll need annual boosters of both. And so you can just get one shot and it'll take care of both. I think that's probably likely to happen in the next couple of years. The second part of the question, though, I'll tell you what, that is a $3.5 billion question, because that's about how much money that has been spent over the last 20 years trying to find vaccines for flu that would do the same thing. And and so it's the same approach with COVID. There's a lot of work, a lot of research being done to see if we can create a vaccine that even goes beyond the really good ones that have been created so far, but can think ahead and can basically
Right.
protect us versus anything that comes up.
Like a smart vaccine,
Yeah,
right?
like an
Yeah.
AI,
There you
right?
go.
An AI.
There you go. There you go. I want my cut. I want to get paid for
There you go.
that.
We're not there yet, though, and that's not in the next few years either. But eventually, hopefully, we can get there.
So, given that and what you just said, folks are still hesitant and they are like, listen, this stuff is going away and it changes every 5 minutes. I'm okay. I don't need it. We still have a lot of that in our community. What's your response to that?
Oh my goodness, it's heartbreaking, and it's also a reality that we face, and it's something that in the setting of a pandemic in this modern age, where certainly social media can amplify voices very quickly, that it's been one of the major challenges that we face. In fact, I would venture to say that misinformation and disinformation, which means that, so misinformation is just sort of like rumors and questions and things like this, but disinformation is the active practice of trying to spread information that is knowingly false to do harm. And we've seen both around vaccines in general, but very specifically around the COVID vaccine. It's done a lot of damage. The misinformation and disinformation has led to people being uncertain because they hear different things from different sources. And when you're just not sure, hearing things from all these different directions, it causes some people to just not really feel confident or sure.
Yeah.
And this is something too that is against the backdrop of a medical sort of system that certainly some societies and some communities have not had trust in our medical system to start with. And
Yeah,
so,
particularly in the African American community. I mean, that was a huge part of our effort, was overcoming that doubt and that mistrust of the
yes.
medical system in general. Yeah.
And for good reason. There were many reasons why that mistrust was there. And so and the hesitancy that we see and or vaccine resistance falls into sort of two different camps. or categories. One of them is that lack of trust, right? Because there's a lack of trust in me and the vaccines and doctors in general and hospitals and pharmaceutical companies because of harm that has been done in communities, especially communities of color historically.
Yes.
The other one, though, is a little more sinister because that's where the resistance or hesitancy comes from. Than the this not so much lack of trust, but this active, almost conspiratorial approach to discredit actual, truthful, factual information, and it is heartbreaking because a lot of the misinformation and disinformation is, quite frankly, responsible for thousands of deaths that could have been prevented had people had more ability to process this. I think we've made quite a lot of progress in the category of those who don't have, who have had a lack of trust. We've made a lot of progress because a lot of work to outreach to and listen to and talk with trusted sources in lots of different communities so that we all could make sure that these life-saving measures were understood and available. But that doesn't help in the disinformation category. That disinformation category is something that is much harder to combat because you can't combat it with just building trust and just giving information.
Well, some people don't want to be confused with the facts, that's for sure.
That's right.
And, one of the things that we tried very hard to do and continue to do with the vaccine outreach and education network that we are doing through the National Urban League and in partnership with the CDC and the National Action Network and others is really try to get into the community where there is a great deal of resistance, where there is a great deal of mistrust, with trusted ambassadors armed with the right information, not to make you feel guilty for not being vaccinated or not to berate you or humiliate you, but really to just help give you the information that you need to make a decision and an informed decision one way or the other. But that disinformation piece was so critical because you had people who were purposely misleading and providing information that could be debunked with even just a minimal amount of research or explanation. But it was easier. It was easier for people to believe the disinformation because it came from someone that they looked up to, admired, respected. So it was very dangerous when you had people who were out in the community representing themselves as subject matter experts, and they were really, like you said, responsible for COVID-19 deaths that didn't need to happen. So I'm hoping we are at a point, and our outreach and the work that we are doing here at the Urban League, we have mobile clinics, we have community-based clinics, we work with partners like BJC on health fairs. We're doing everything that we possibly can to make sure that we are providing information, but that people have access to testing, because it's still important to get tested, that people have access to testing, and they also have access to vaccination clinics in their own neighborhoods. But here's something that I am concerned about, and I wonder if you have any insights on this. As this emergency declaration is winding down or going to be lifted here sometime in May, that means that some of the services, particularly in communities that are most vulnerable, may not be as accessible. They may not be free. And people are going to really find themselves between a rock and a hard place, I'm afraid, if they don't have insurance, if we haven't expanded Medicaid, if we haven't done everything that we can to make sure that they have access to healthcare and to the vaccines and just, even to a doctor. So what do you think about that?
Well, first, I want to go back and also just say thank you to you and the Urban League for being that very trusted source that has helped make a difference. We're in a battle now against mis and disinformation, and we, and you're play such a critical, important role. And I thank you for all the lives that you have helped to save. But I have the same concerns about the expiration of some of the declarations. You know, it the designation of a public health emergency, and then some, and also the de-escalation of that, has everything to do with availability of resources and doesn't really reflect whether or not a pandemic still exists or not. That's actually a very long spectrum of things. It's not a black and white turn, on and off. You turn off the switch. It is
Right.
very much the situation that eventually,
Pandemic
over time,
over. No.
that's right. That's right. It's never going to be over, but we're going to be living with COVID forever. And it's also something that we can live with and that we can manage. And, vaccines are the key. But the declaration at some point does end. And what that means, and I think you brought up some of those concerns that we may see, are that those declarations allowed for federal and state funding for services, and that includes testing. So free testing that's available, some of that will no longer be free, and some of it will. And as far as availability of vaccines, availability of treatments for COVID. So if you're a high risk person, you still get COVID, and you can and should take the medication that's the main medication we have is Paxlovid that's available. Most people that are high risk, it works very well. Access to that and or cost may be a huge problem once those declarations are rescinded. And so we really do have to watch very carefully, because what I'm afraid could see is a continuation of some of the disparities that have existed for a long time.
Exactly.
And that is absolutely a concern. And it's something that I don't think that we have as a system been able to, we won't, we may not completely understand the full impact of that. And I also think we're not necessarily ready for that impact. But it is something that we have to watch very carefully for, and that is one of the downsides that could emerge from the de-escalation, or the coming away from the status of it being a public health emergency.
So what should we be doing? I mean, in the community, regardless of whether there is an emergency declaration or not, what are some of the things that we should be doing to protect ourselves, protect our community, try to stem any community spread that may be still that may pop up as a surge, especially as this emergency declaration is lifted? What should we be doing?
Yeah, and I think we're a recommendation I have for an approach to this moving forward is to also say, let's just change a little bit how we live our day-to-day lives, and that we look at this in a way that it's not just like, oh, there's COVID here, oh, there's flu here, but let's just think about overall for those types of respiratory illnesses. So the way to protect ourselves and the community really revolves around a few simple principles. One of them, be up to date on vaccines, both COVID and flu vaccine. If you are up to date on those vaccines, you have markedly reduced your risk of becoming seriously ill, period. There is no debate about that. It is 100% certain that we get marked, huge protection versus those things. Even if you've had COVID before, getting vaccinated on top of it provides the best protection there is. So that's one thing. The other thing, to then protect both yourself and others, is a consideration that even when we don't have masking requirements, if you're a high-risk individual and you're going to be in a high-risk situation, and what is a high-risk situation? Well, it's being indoors with a lot of people that you don't live with, or even just one person that you don't live with, but the more people there are, the more chances are, where you're going to be in close proximity, indoors, with people you don't live with, especially for extended lengths of time, and especially if there's a lot of COVID in the community, circulating in the community. In those situations, even when there's not a mask requirement, you may really want to consider wearing a mask in those situations to not only just protect yourself, but also if you happen to have COVID and didn't know it, or flu, that you're protecting others around you. This really comes in very importantly if you're going to be visiting somebody who's very high risk. And the
Yes.
classic example I talk about is around, say, Thanksgiving, and you're visiting grandparents and older family members, or those who have, some severe underlying health problems. In those instances, you really do want to make sure that you're trying to limit the time indoors if you can, that you're maybe masking when you're not eating, and also that's a role too, to do some testing just before you are in close proximity to high risk individuals.
That's a good point.
There's one other part to this too that I think we want to think about moving forward, is that when we have symptoms of any of these, flu, COVID, they kind of all overlap, but things like fevers, cough, runny nose, stuffy nose that's new. Obviously, it's not, maybe just a tiny little thing, but something that's new and different, sore throat, these things that are new and different, that we should, when we can and when it's available, to be able to test to see if we have COVID in particular. And then someday we're going to have at-home flu tests too. And then if that, and then we, if it's positive, we stay away from others until it's run its course. And if it's negative, though, we may still go out and do things, go to work, go to visit other people. But in those cases where we have any symptoms whatsoever, that we wear a mask when we have symptoms so that we're protecting others. And when it's possible, I know not everybody has an employment situation where it's possible, but when it is, to try to stay home when you have those symptoms. But we all know that some people don't have the luxury to be able to do that.
That's correct. And the thing about it is, I keep thinking about early on when we were in the throes of the pandemic, and it was just that population that you just talked about. It was people who could not afford to stay home, who constantly had to go to work. They had to go and put themselves at risk over and again because they couldn't afford to, whether they were in healthcare or other jobs that where they didn't have the luxury of being able to just stay home if they didn't feel well. And I hope that we don't have to go back, because that really, I think, that when you saw the impact in the community for people who may have been in jobs where they were working entry level jobs where you couldn't stay home, or they were working whatever the skill set required them to actually have to be out in the public. There was no work from home option, and so those are the people that I worry about the most.
And quite frankly, those were some of the true heroes of the
Absolutely.
First year of the pandemic. People who are working in our grocery stores, working in public transportation. Healthcare workers certainly were at some risk too, but we are also have much more equipment to help protect ourselves. And everybody who is working out there truly on the front lines in those service locations where society still had to keep moving. So those were some of the real true heroes of the first year of the pandemic.
Well, I know there were a lot of lessons learned, and I smiled a little bit when you were talking about how the information that was coming to you would just change. Seems like when you were in the middle of a lecture or in the middle of a seminar, but it is because of that knowledge, and it's because of those advances in that information that I believe that we were able to get ahead of this, if you can say that we did, or contain it, as we did, because there was that information and there was that just sole focus on creating the vaccines and trying to get as much information about treatment and care for COVID-19 as we did. So again, I thank you for being with us here today. I thank you for sharing the knowledge and the information. I learned a lot. Is there anything that you would like to share, want to leave us with? Because again, it's not over just because someone chooses an arbitrary date. We still have to make sure that we're taking care of ourselves. So is there anything else? You've given us some great advice on how to protect ourselves going forward. Anything else we should know?
I think the main, just the main emphasis is to be up to date with your vaccines. And also, if you do happen to get COVID and you're in a high risk situation, over 65, lots of underlying health conditions, pregnancy, that you also ask and seek treatment with the medications that are available, because they do make a difference. So these are things and that is going to be the same message probably for the next 20 years. And so be up to date on vaccines, get treatment early.
I can see it, and I can see a whole campaign around that. So that's my communications hat on right now. Thank you, Dr. Lawrence. We really appreciate you coming and spending some time with us at the All In podcast. We'd love to have you back, because I have a feeling we're going to be talking about this for quite a while. So you have a home here. If there's anything that you want to share, just reach out to us. We're happy to have you back.
This has been my pleasure. I was very glad to be able to talk with you today. Hopefully we can do it again.